Good afternoon and welcome to the Bob Woodruff Foundation's webinar on supporting mental health needs of military connected children. I'm pleased to see so many individuals joining us today. My name is Hunter Rust and I'm a program officer here at the Foundation. I welcome everyone joining the call and look forward to hearing from our expert panelists. For those of you who may be less familiar with the Foundation's Got Your Six network, it's the largest network of organizations serving our veteran and military community. The network is made up of veteran serving organizations of varying sizes, maturity, and focus areas across the country. I'm confident this material we'll be diving into today is helpful for all of our partners who are doing work across the country. Before we dive into the panel discussion, our CEO, Anne Marie Doherty, would like to share some remarks about military child mental health.
Hi, everyone. I'm Anne Marie Doherty, CEO of the Bob Woodruff Foundation. If you're here with us today, it means that you care deeply about the mental health challenges children are dealing with. And you likely know that these issues are even more pressing and urgent when it comes to our military children. That's because the commitment to service doesn't end when the soldier comes home. Taking care of our veterans often means that family members become full-time caregivers, and that can take a huge toll on kids. On top of that, military kids have to deal with frequent moves, deployments, and a greater likelihood of financial or housing instability. At the Bob Woodruff Foundation, we're committed to doing everything we can to support their mental health and well-being. In 2023, we invested over $1 million in this area. This year, we're continuing to identify and invest in the most effective programs. This issue will stay at the top of our priority list for as long as it needs to. April is the month of the military child, and we thank you for joining the Foundation and our panelists today as we work to address the mental health needs of one of our nation's greatest treasures, our military kids, this month and every month.
It's my great pleasure to introduce our panelists, Dr. Nicole Ayers, Clinic Director of the Stephen A. Cohen Military Family Clinic at Valley Cities, Christy Dean, Regional Director of the Stephen A. Cohen Military Family Clinic at Endeavors, Tina Rose, CEO at Big Brothers Big Sisters of San Diego, Dr. Linda Schwartz, CEO at Children's Research Triangle, and lastly, our moderator for this session, Shannon Razadin, CEO at Military Family Advisory Network. Each of our panelists and moderator bring a unique perspective to this topic. Very excited to introduce them. And Shannon, take it from here. Thank you so much.
Thank you so much, Hunter. And really, thank you to the Bob Woodruff Foundation for bringing us all together. This is an incredibly important topic. As a mom of a newly minted 6-year-old and a 7-year-old, I think we all know that mental health among kids is a complex issue. It's something that has really evolved over the last few years, in particular, as we have come out of the pandemic and we're seeing social media and the implications that that has for our children. And the military community has these added nuances that can make life even a little bit more challenging. And the kids are really part of that experience as well. And so I want to open up first with a question for each of you, really to talk about what you're seeing broadly as it relates to kids and mental health, and then also what you're seeing among military connected children. And that could be active duty connected kids, or it could be those who are in veteran households as well, and maybe fulfilling unique roles like caregivers. And so, Dr. Ayers, we'll start with you, and then we'll do a round robin here.
Yeah, I think one of the challenges we see with kids in general is there's just a lack of safe places than there used to be with the kind of frequent use of social media, right? And so in some of the schools that we do care in and some of the military connected kids and just kids in general we work with at the clinic, we are seeing increased bullying. But I think some of that is just there's just greater access to our kids 24 hours a day. It used to be you could go to school and if you were being bullied at school, home was still the safe place. But with social media and you have the internet in your pocket on a phone, kids are being bullied via the internet. And so there is just this inability to escape and have this safe place. And so we work with all that a lot, both in our clinic and the schools. And then we also see just challenges with healthy technology use, right? Being able to set boundaries and turn it off. We have this challenge as adults, and it's even more so, I think, when we see it with kids. And with some of that inability to turn it off, we are seeing anxiety and depression. And then with military kids in general, we just see those challenges with transition, right? That our kids are moving in, they're having to go into new communities, new schools, which is learning new norms, new expectations, creating new friend groups, trying to fit in a time where you may already feel awkward and uncomfortable and not sure how you fit in. And so those challenges we see, with kids in general, but really see it with our military kids who are moving 4 times more often than, their civilian counterparts.
That's something that really rings true in the data that we see, is that these frequent moves add this level of complexity, and the disconnection from community and the nuance of figuring out how you plug into your local resources is incredibly important. Christy, can you go next?
A lot more exposure to trauma, either personally or awareness of trauma around the globe. That again, impacted by the presence of social media, and just kind of the shrinking globe that we're living in for these youth. Something particular to military connected children is maybe they don't have the same immediacy of a support system when they go through these frequent moves. Their grandparents are not there, or they haven't established, new support groups and connections. So that can be an additional challenge for them in their network. And then occasionally there's some unique pressures like you're going to be the man of the house while I'm deployed kind of messaging. Kiddos can really take that to such a level of anxiety and take that on as a big stressor.
Those are such great points. Tina, you serve the broad community, right? So at Big Brothers Big Sisters, you're not just serving military children, but obviously you're in a location that is densely populated with military families. Can you talk a little bit about what you're seeing broadly, and then really kind of some of those nuances and unique things that you see among the military connected kiddos?
Yeah, such good points already. In our community, and I'm really across the country, we're seeing that the pandemic just isolated kids and it reduced their network of support. Those people they used to count on, they just don't have those tight connections with anymore. And that couldn't be more true with military families who are moving and relocating. And we're just seeing that every time they move and they lose friends, they have to make new friends. It's bringing, those feelings of instability and loss and anxiety. And they're having a hard time creating new meaningful relationships. Like our kids got out of practice, right? Creating those relationships, forming relationships. And really that has a huge part of their own self-identity. So, we know across the country, 1 in 6 young people between the ages of 6 and 17 experience a mental health disorder every year. So it's pervasive, and it's really impacting our military connected youth.
Thank you. And last but certainly not least, Dr. Schwartz, can you talk a little bit about what you're seeing locally, and then also just through your day-to-day work?
Yeah, absolutely. So at Children's Research Triangle, we work with high-risk kids, and that can mean they live in communities that are fraught with violence. It can mean that they come from homes where there's been domestic violence or child abuse. We work with military-connected kids. And one of the things that's been so striking since the pandemic is that these high-risk kids lost their safety net. They lost eyes on them, right? They lost teachers, they lost daycare providers, they lost people who were wondering if something was going on that was really troubling or problematic. And so coming out of the pandemic, what we've been seeing is that group of children, their risk has just grown, and their mental health challenges have grown exponentially. And we work in schools and domestic violence shelters and vet centers and other social service agencies. And we're hearing from the people who have been working with these children for decades, experienced teachers. They've never seen such high levels of dysregulation. They've never seen such high levels of interpersonal conflict, of aggression amongst the kids. And one of the things that we're finding troubling and fascinating is we screen all of our kids for trauma. And our overall population, again, come from very high-risk Chicago communities. And 68% of our kids have experienced 3 or more types of trauma. So that could be loss of a parent, it could be child abuse, it could be neglect, it could be homelessness, it could be domestic violence. Our military connected kids, 90% of them are reporting 3 or more types of trauma that they've experienced. So even in comparison to children who live in communities where we know there's incredible trauma every day, these kids are standing out as really experiencing incredible levels of risk.
It's a great point, and one of the things that, as a mom, of 2 young kids, one of the things that teachers we've heard a lot about was, some of the younger kids, they didn't go to the preschool and even kindergarten to be able to set up some of those foundational social skills, and so then when they enter the school system, there's this whole level of education that has to happen that is not, just the academia piece, but also how you engage in a social environment, which has been something that has been fascinating to see. And then when you think about military kids, there's this added nuance of they were still moving during the pandemic. And so you bring up, the fact that people lost that safety net, they lost the eyes on them and the ability to report or, help navigate any of those challenges. And you had then families still moving during that. So it was compounded in a lot of cases for military families. I'd love to chat a little bit about some of the barriers that you see to serving these children, to getting them connected to the support, and also not just the children, but also how you get the parents connected and their caregivers to the support, knowing that they are really the gatekeepers in a lot of cases and the ones who are helping their children navigate these challenges. So, Christy, I see you nodding a lot over there, so I'll start with you on this.
Well, just as my fellow panelists have commented, there has been this huge uptick in need. We are experiencing a crisis in mental health care for children. It was occurring before the pandemic, and it dramatically worsened during and after the pandemic. But another thing that occurred during that time frame is a shift in the workforce for mental health providers. So suddenly, there are jobs everywhere for licensed mental health providers, and the ones who are more experienced, more tenured and skilled, a lot of them chose to go into work at home, private practice, more comfortable roles. And so to find good mental health care available publicly in the community, to find mental health care in a nonprofit setting that or in a school setting that's really globally available to these families is just a huge challenge. And then to add to that, you have to have special training and a special skill set to work with these kids. Not every provider is really capable and trained and adequate at that. And so there's a huge need for qualified providers to work with children at the same time that there is such a demand for it.
That's definitely what we're seeing as well in our community, a shortage of mental health workers. And I was going to say the hopeful thing is that there is research that indicates that, especially for adolescents, having a supportive relationship with a caring adult has really been shown to be beneficial for preventing mental health and as they grow up and as they develop. And so that's where we saw an opportunity. Big Brothers Big Sisters has an empirically based mentorship model. We can provide a supportive adult relationship and really help foster their sense of belonging and self-worth and boost their confidence and build their resilience. So, we've seen that not only that, but also research shows that it reduces their depressive symptoms and improves their academic outcomes. So in the midst of this mental health shortage, a shortage in the workers, I think that we can provide support for our youth in a unique way through mentoring and being there for our youth during this time.
That is so important. One of the things that we see a lot in the research is loneliness and the connection between loneliness and mental health, but also other indicators and things that we need to be aware of and watching as well. Dr. Ayers, can you talk a little bit about the school setting? We had a great conversation about a year ago on a previous panel, and I think that schools are, in a lot of cases, are that first line of defense and really a great mechanism for connecting people to resources. My son goes to therapy once a week after a traumatic incident that he had, and it's been a game changer for us and our family. So can you speak a little bit to that as well?
Yeah, I think it's a great resource being able to provide care at school, because not only do we have a shortage in providers, we have a shortage in TRICARE providers in general. So we have, for us identifying the need here in our community, we just got curious of how we would solve it. And so we started working with some of our local school districts to be able to provide our care in their setting, which helps to decrease some of the barriers that our kids find in getting to care. So, for our adolescents, the age of consent in Washington State is 13. So a 13-year-old can consent to their own mental health treatment, which is incredibly vital for some of those 13-year-olds who may not feel like the family system at home is supported. And so they can get the care that they need while we try to work on making those connections with their family and, adapting in that relationship. Also, it decreases the barrier of even getting into our clinic, right? We can see them at school. I think the biggest success is working with the school counselors who know those kids, who know their schedule. They know if, a teen is trying to avoid their math class every week and we cannot schedule during that time. But we work with those counselors so that we can provide the supports that they need there on the site. And it's been a really positive, I think, way of impacting not only just the shortage in the community, but also bridging some of the gaps that kids face with just trying to physically get themselves into care or get that support they need to get into care.
Yeah, and can we talk a little bit about what partnerships look like here? I think that in a lot of cases, the referral piece is really important, and recognizing the limitations of what you may be able to provide and when it is appropriate to refer to another organization. And Dr. Schwartz, can you speak a little bit about that? You obviously work with children who are experiencing trauma in significant ways. And so talk about the referrals you receive and then also how you work with partners in the community.
We design our program to do as much as we can to reduce those barriers to access. And one of the things that has been a positive shift post-pandemic, because one of the biggest barriers, I mean, yes, there's transportation, there's cost, there's lack of affordable and competent mental health providers, and particularly those who have training working with specific populations like military connected kids. But one of the biggest barriers is just an appreciation that children's mental health matters and that it's important, and that if we don't address it, there's consequences throughout the child's life. And so what we do is we partner very much like Dr. Ayers with schools, but also with other social service agencies, like I mentioned, and with vet centers. We have 22 partners, 7 of them are just regular referral providers. And so we save slots for them so that they know that they'll have access to mental health for the kids that they work with. But 15 of those are partners where we send our clinicians to the sites, into the communities, so that there's no barriers to access. We all of our services are no cost because we use grants and private donations, and so there's no paperwork, red tape, difficulty, actually starting services. When we work with vet centers, and we're currently on site at a vet center in Evanston, one of the biggest barriers that we're there to overcome is the idea that vet centers have services for adults. But in terms of their funding and in terms of the clinicians who are working there, they're working with the adults. And so the idea behind our partnership is what can we contribute to support the children in these families? Because clearly it's a huge gap in the services that are being provided for these families. And so that's how we partner. Our partners provide space and they provide a liaison to work with us and give referrals, and we take it from there with the services.
It's so important, and I think that we are all trying to create this no wrong door, opportunity. And so you never know where people are going to come in, and being aware of the local resources and how to plug people in. I think especially when you're moving on average every 2.5-ish years, sometimes more frequently for certain MOSs. And so I'd love to talk a little bit about the parent piece. The military has this culture of resilience, which is a sometimes loved, sometimes hated word in this space, and sometimes that gives people the perception of like we'll figure this out on our own, like we've got this. What are some of the things that you look for when working with a parent or a kid, and what are some of those, those flags for you, that help you realize that they might need a little bit of extra support? And Christy, if we could start with you.
I think it's important to remember how scary it is for a parent to reach out and get mental health care for their child. I mean, we have all the stigmas for going to get mental health treatment for ourselves that we are trying to chip away at as a community. But the fear of being judged, the fear of, is this going to be all my fault as the parent? What in the world is my child going to say, to this provider? All of those things, it's really, really intimidating to open yourself up to that. And so anything we can do to kind of be a bridge to normalize this, to set the expectations for that parent, and to talk about it in a way that someone or another child you worked with was really successful, to kind of normalize the experience and talk to them about the expectation. It doesn't mean that we are labeling your child as having a mental health problem for life. It doesn't mean that your kiddo is now going to be considered, special needs or crazy or any of those things. But to really just put it to them as a tool and a resource that can help with this difficult transition, and give examples of ways you've seen it help others. I think it's also really important because a lot of times that psychoeducation and coaching piece is a big part of what we do. We're spending a lot of time preparing the parents to understand the themes and to really be better prepared to assist with helping the child with their emotional regulation, all the things they can do all week long when we are just seeing them for that 1 hour.
I can only imagine what my 6-year-old therapist knows about me. So that really resonates. Tina, can you, Big Brother's Big Sister, one of the amazing things is in most cases, regardless of where you move, you can probably find a Big Brothers Big Sisters or a partner organization. And I think you probably have a lot of families and a lot of children who are entering your organization for support that's broad. Can you talk a little bit about that, and what are some of the indicators, and how do you navigate that when you think a child might need a little bit of extra support?
Yeah, I think, it brings back that African proverb to mind. It takes a village to raise a child. I am a parent of 2 teenagers, and I know that full well right now that I cannot do this alone. I need all the help I can get. And so really positioning our parents as our partners and, bringing them on the team with us. You are a part of this team. You are part of supporting your child's mental health. And how can we do this together? I kind of like to envision it as like a cocoon of collaboration, right? We're building this ecosystem of support around each of our youth, really building their resilience, their confidence, and hopefully someday they're going to fly out of that cocoon. They're going to go on their own empowered path. But right now we need to have all the resources we can around each of our children. And so I think positioning it like that with our parents and supporting them and knowing that they're a part of this team, a critical part of this team. So Big Brothers Big Sisters works with them by providing trainings, helping them better understand mental health. There's a lot of unknowns as parents, so just providing the education that can help them better understand how to support their child.
That's awesome. And for Dr. Schwartz and Dr. Ayers, I'd love to chat a little bit about the nuances a little bit more specifically for military kids. And so, Dr. Ayers, we can start with you. Military families experience things like separation. They are not necessarily located near a network of support, the transition pieces. What are some of the things that you have seen presented recently, last couple of years for military children in that respect? And then what are some of those like proven concepts and things that you've done and implemented to help support those children?
I think one is involving the parents, I think is what we're talking about, is like making that parent your ally. And especially with military connected parents, of reminding them that you've never done anything alone, especially in the military. You have a squad, a troop, a platoon, a battery, whatever it is, you don't do it alone. And so you don't have to address these challenges, whether it be with a child, with a family system, alone. I think some of the signs of challenges that we often see are are similar, I think, across children, but when we see changes in behavior and things like sleep patterns or outbursts at school, particularly around transitions, whether it's that military parent is leaving or coming back. So you can see that reflected in the school setting, moodiness, sadness, less social, withdrawn, changes in the classroom or challenges in the classroom. But also listening to language that's being expressed. So are they expressing worry? Is there what ifs or I'm scared of this? If there is a conversation about death or sometimes bad guys or things like that. And so I work with kids and I work with parents to first just get curious before we react and just ask, what do you mean by that? Ask parents or kids or teachers, is there anything changed at home lately? Is there anything changed at school, right? Is there been a new student in the classroom that maybe there's some conflict, or is there an issue with a teacher or with a particular subject, right? And then asking kids, can you tell me more? Because I think sometimes, especially as a parent myself also have a 7-year-old military kiddo, of just my reaction as an adult is to be like, huh, but really just taking in from a place to be curious is like, what does this even mean to you? Because kids hear and experience a lot of things, whether it's at school, in the community, in different groups. And so really just starting from a place of inviting kids and inviting parents in as allies and as partners, as part of the team versus, kind of the traditional, what we tend to think of like, I'm the expert and you're the person coming to me for expert advice, right? We're a team in this, and being able to work collaboratively in that way.
Yeah, no one knows your kid better than you as a parent. And so that makes such sense, bringing them along in this journey and being a team. What about you, Dr. Schwartz?
I think we really try and take a strength-based, empowering approach, right? Like along with the culture of resilience, there's also I think, the idea that you don't want to go to work without your tools, right? We all need our equipment to get our jobs done. And that includes coping tools. And when, like Dr. Ayers was mentioning, when we observe all of these various signs that something is going on, that there may be some mental health struggles, going on within a child, within a family, um, we want to approach this from what are all the strengths that we're working with? And as parents, we all like to hear first what our child positively brings to the table, right? Nobody wants to just focus on the weaknesses and the challenges. And so we come at things from more of let's first assess everything that's working and that's positive. And that's what we're going to take to build on. But we can't build without the tools. And so that's why so many of the therapy models that we use a variety of evidence-based therapy models that are really designed at building resilience, building coping, building a feeling of security, building attachment, building attunement, developing skills both with the parent and the child so that you feel like you've come to this with with something that you can use, with something that will be effective, rather than just feeling like I'm feeling a little bit hopeless. I don't know exactly how to help my child. I will throw out something that we've found very helpful in working with parents. We've been part of the National Child Traumatic Stress Network for I think 14 years now through SAMHSA. And they do have some wonderful resources, and I can add this to the chat, but they have a toolkit for identifying and understanding trauma and resilience for military parents and caregivers. It's really helpful. It's a very nice checklist of things to look for, but also a checklist of things that you can do to be helpful to your child, how to talk to your child. So it's something. I know we've been talking about psychoeducation. Psychoeducation is so helpful because it's not as threatening, right? It's just providing information that anybody can benefit from.
And for those of us who are less academically aware per se, can you just define psychoeducation for our audience?
That's a good question. I think about it as education that's focused on kind of social, emotional, psychological factors. And so it's very broad, right? Like, I mean, psychoeducation can be what I was just mentioning, toolkit for helping to identify risk with your child. It can be understanding the context that a child may be living in, whether it's a military family, whether it's a community filled with violence, whether it's a home where there's violence, and then providing information that people can use to understand and also problem solve and make decisions.
And it's a great tool for kind of breaking down some of those barriers and stigma and that anxiety about like walking into a mental health clinic for my kid might be scary. But when my team's out partnered with Wear Blue, we can provide education and psychoeducation in a way that's already familiar and comfortable so that when that family might need some support, they know they put a face to a name, they know the organization. And so we try to do that a lot with our partnerships of like providing parent nights at schools and ways of providing that information, so we can plant that seed. So if there is a challenge that arises for a family or for a kid, then they feel a little bit more comfortable walking through that door when they need it or making that phone call.
Thank you. Christy, can we chat a little bit about what you're seeing locally at the 3 clinics that you have in Texas? I think that part of what you do so well at Cohen is really addressing a diverse set of needs. And that's everything from actively serving family to veterans to wounded, ill, and injured. And so, can you talk a little bit about what you're seeing in your clinics?
So I am a regional director and I oversee 3 different clinics that are part of the Cohen's network. And I couldn't have 3 any more diverse, different communities. But I think that's true of every military installation, of every military town, right? They're very unique communities. And so I have examples within Colleen, El Paso, and San Antonio of kind of a small, medium, and large city and community, which makes a big difference. Some of those small town environments are hard to build trust. They're hard to gain acceptance in. And then you add to that Fort Cavazos, formerly known as Fort Hood, for those of you who haven't caught up. Fort Cavazos has had such a history of trauma. They've had just one after another of really difficult violent experiences, loss experience. They're on the news all the time. And it makes it a very closed, guarded system where they don't just want to let anybody in for that community. So that has shown a difficult system to kind of break into, a difficult community to connect with, and then therefore sometimes a unique challenge of accepting help, knowing about the resources, all of those things. Then in contrast, El Paso is sort of a medium town, high deployment community, but they tend to go out for training exercises versus long, difficult deployments like they do at Fort Cavazos. So it has a lot more support in general, within that community. We do still see with both of those communities a very high percentage of active duty families. So we get a lot of the active duty type issues, such as adjustment to deployments or dealing with pressures of PCSing or, those kinds of things that you experience that are more military connected. Whereas in San Antonio, it is it's a good mix of veterans and active duty. And so the presenting issues are a really good mix of everything from just kind of that normal social pressures and experiences that children go through of being in school these days, bullying, all of the different anxieties that they have and social issues. We get a lot of that, a lot of trauma and loss, but it has a different flavor to it because it is not as distinctly connected to active duty as the other communities.
Thank you. That's super helpful. And I think that gets at there's not a one size fits all model for anyone. And the military community is no exception. I think that sometimes you might think that you have this one program and then therefore it works. But the other reality is that there are programs and pieces of different things that you can pull and implement in other places. And I think that one of the opportunities that we have here is really sharing what's working. And so, Tina, can you talk a little bit about Operation Big and what you're doing for military kids through that program?
So 20 years ago, we launched Operation Biggs. It was the first of its kind one-to-one mentoring program on a military installation here in San Diego County. And it was really designed based out of calls from spouses at Camp Pendleton. The deployments were increasing and they were asking for extra support. And so what started as a one-to-one program in schools to serve active duty families who had a child with a deployed parent really over the last 20 years has grown to be community-based and community-wide, and it serves any child that has an active duty veteran or Gold Star parent. And it's actually become a national program, so it has spread across the country to other places if you're looking for it in your community. But it's been truly impactful. Just last year, our Operation Biggs youth, 94% of them that enrolled in the program maintained or improved their emotional regulation, and 87 improved in their depressive symptoms. So talking about mental health, these are just, huge positive things for our youth. And we see that when a youth has a trusted mentor to turn to, they are more likely to, feel confident, capable, resilient. And we're seeing, all those great behaviors and mindsets build, and their overall well-being improves. So it's just been exciting to watch it grow and see it spread across the country. And I think the extra bonus is that it's great for the mentor too, right? Actually volunteering and mentoring boosts your emotional well-being, makes you happier. And so it's a win-win for the volunteer and the child. And we hear from our families what a support it's been through the years during times of deployment, during times of extra stress, transition. And the neat thing about these relationships is they can grow. They can live beyond, just being here in San Diego. No matter if that family leaves, many times they're staying in touch for many, many years, if not the rest of their life.
That's incredible. And what you're doing, like in what organizations like TAPS does as far as how to support kids of the fallen, as far as the mentor programs, you're right. It's a win-win. It helps the child. It also really provides that self-efficacy and support and also connection for the person who's doing the mentoring as well. So that's awesome. Dr. Aarts, can you talk a little bit? We talked about there's not a one size fits all, package here, but let's talk a little bit about the nuances between middle school age kids and high school age kids, what you're seeing. This has been, I think, military or otherwise, things like social media, and just what is the right technology access that kids have. They've been hot button issues. And so I'd love to get your perspective there.
Yeah, there are definitely some unique differences between the middle school age and the high school age, and with both like the transition and the pressures. And so in middle school, we see this age where kids are not really a child anymore, but they're also not fully a teen either, especially that 6th, 7th grade, where they're in this transition from like, what does this even mean? I just was in elementary school yesterday, and now I'm with all of these other kids and these teenagers that are just having increasingly different challenges that they're facing. And so that is tough. Middle school age is tough in that way. We also see that there's gaining independence, right, and taking more responsibility. But this also means that there is this testing the limits as times go on, trying to figure out where are the boundaries in my family, in my community, in my school. There's new social expectations when we transition into middle school. So this is where you see more cliques, although we are seeing this younger. I do K-3 groups right now. And they have cliques, oddly enough.
Mhm.
But we also see this increase rate of, bullying because you're in or out of a specific group. There's also a really rapid change that happens in the brain between about 9 and 14. And that's that second window of opportunity. So we talk about this between ages 0 and 3. There's a huge amount of brain development that happens again at 9 to 14. And this is also timed with puberty. So there's hormonal changes. So there's the positive during this is there's improved cognitive skills and emotional control that's developing in middle school and into high school. But there's also just an increased sensitivity to social evaluation, emotional reactions, sensation seeking, and exploring their identity. And I think that is one of the biggest things we see right now in our middle school population is just people really trying to figure out who they are, how do they fit into the world, what does their identity look like? And this can create a lot of conflict because their identity and their identity may be different than what their parents' idea is of their identity or what is an acceptable identity. And then as we move into high school, we see all of these things continue, this building of social networks, but we also find that there's a lot of pressure for high school age kids to just have it all figured out by the time they graduate. And we hear this a lot from our high schoolers is right. You have to know what you want to do, what you want to go to college for. What are you going to do with your whole life? And we joke internally, like, I don't know that I necessarily know what I want to do when I grow up, and I'm much older than high school age, let alone a high schooler who's, 17, 18-year-old trying to figure out what does the rest of my life look like. And so with that, we see a lot of stress and anxiety, but also a lot of paralysis and depression, right? Kids will then just feel like they can't move any direction because they have no idea what it is they want to do. Or there's a pressure from their family system to engage with lots of social activities and extracurricular and volunteer and all of these things to make them good intention to make them well-rounded, but puts a lot of pressure on kids who are still trying to figure out where they plug into the world. How does this look like? And then we see more peer pressure in high school, right? And so here kids are learning to say no, ideally, how to set boundaries, how do we stand up for the things that we believe in, and how do we, or what our family, teaches us is to values. And then as we age, we just see a lot less sleep, which impacts the mental health of our youth. There's more social activities, there's more things to do, there's more expectations, we're staying up late. And so that decrease in sleep also impacts just our overall functioning.
I cannot imagine growing up today. And I think that we can all probably agree on that. It's complicated at best. And so I think one of the things that's important to remember is we've got to put our oxygen mask on first before really being able to provide that productive support for our kids. Dr. Schwartz, can you talk a little bit about what you see as far as veterans' mental health and how that impacts their children?
Sure, absolutely. The mental health of any parent impacts their children, right? And so I read an interesting study a few years ago that children are often more reactive to their parents' emotional state than to actual danger. And so keeping that in mind when we're thinking about what it's like for these families and these parents, the impact of a parent's mental health issues, whether it's PTSD, whether it's depression, on the child, the child is part of a family system. And if any part of that family system is struggling, that affects everybody. And so let's take PTSD, for example. I mean, those symptoms can be damaging not only to family cohesion, but also to a child's emotional and developmental functioning. If a parent is experiencing grief and sadness and fear of loss, that can lead to difficulties in establishing and maintaining attachment, especially with children. Aggression and poor anger management can lead to rageful outbursts and even family violence and physical abuse. And so there's no doubt that parental mental health has a dramatic effect on children. And children can also develop something called secondary traumatic stress or vicarious trauma, which we talk a lot about with adults who work with traumatized children or individuals, but it can be a phenomenon for the children as well, where they experience the same symptoms as if they're experiencing that stress themselves. And so, one thing we were really interested in is looking at therapy outcome with parents who have experienced military sexual trauma or PTSD. And when we do program evaluation on all of the children in our programs, but we're pulling out parents who screen positive for either MST or PTSD and looking to see if that's affecting the outcome of therapy. So do parents who are struggling with more severe emotional mental health challenges, how does that, are their children faring as well in therapy? What are some of the variables? Because there's no doubt children are part of a family. We can't work with them in a vacuum. And so we have to take all of this into account. So the study is a work in progress, but hopefully we'll have some things that really can help guide treatment even more.
Thank you. That's so important. And I think that sharing information helps us all, work smarter. And if we can learn what's working, what's also not working, I think it's important to make sure that we're sharing those lessons as well. I know I could keep talking about this forever, but we are going around time, and I want to give everyone a chance to answer one last question. For those of you who are working with children on an ongoing basis, are you seeing improvements in their outcomes and their family relationships and all of those things? And we'll start with you, Dr. Ayers, and really go around the room. I think that we really want to understand that, does that consistency really move the needle for children?
Absolutely. I think we've seen it, especially in our school-based program, but just in our youth-focused programs in general, both individually and groups, depending on the need. And so we receive really positive feedback from teachers that when we're doing school-based services, whether it's groups, like right now I do 4 friendship groups with kids learning pro-social behaviors in K-3. And so we see, that collaboration between the school and the teachers and the counselors. We see a lot of positive feedback with them being able to implement the tools that they're learning in group into their classrooms and then in at home by communicating with the parents. And then individually just being able to, I think for us with youth, having a broad definition of who we serve helps in the military community. So it's not just an active duty family, it's not just a veteran family, but it's our National Guard, it's our reserves, it's our Gold Star families, that we can serve all of those individuals and bring those unique perspectives together, individually and as in a group, to just provide improved access for our military families to get the care when they need it. And so in a timely fashion. And then for us, the flexibility to be able to meet kids where they are, whether it's at their schools, in the community, in our facility, can help really get the needs met and wrap around those families and provide the support.
We're absolutely seeing some really promising results. And I think part of it that's going to really make the difference here is to have kind of a layered approach. Some of the things that others have spoken with, Tina, with mentorship, and then some of those psychoeducational services. You don't have to be a licensed mental health provider to work with the parents and to do skill building groups with the kiddos on social skills and all of those things. And so that way we're doing a layer upon layer of intervention at the appropriate phase. And there are a lot of youth that get better without having to go through actual mental health treatment. And then that leaves for those that are really experiencing more of a mental health diagnosis, an anxiety disorder, something that's more significant, they can get that short-term treatment, get better, or we can really connect them with the right care. So we're definitely finding some great results doing that, and it's been very encouraging. We've brought in a special trainer so that I've increased the number of providers at each clinic that are really trained and skilled working with younger children, play therapy rooms with the right tools and resources in there, and then we can dedicate the right staff and the right intervention to that child.
I love it. And the 2 minutes that we have left before Hunter closes us out, Tina and Dr. Schwartz, if we could get to both of you on this question too.
Yes, I will be brief. While our staff is mental health first aid trained, our bigs aren't. But we do provide them trauma-informed care training. But what we see is that just human connection is powerful. We're seeing such positive things when we integrate that into our mental health framework, building more, resilient, supportive, empathetic kids. We're hearing from parents that their kids are coming home calmer. Kids that are suffering from severe anxiety are coming home happier and calmer after they see their big. Everything from, a little sister who struggled with a lot of anxiety to coming back to saying, I don't think this is really for me. And then committing with her big, let's just take it month to month, to now her saying, this is one of the most important relationships in my life. This person is on my team. This is, someone I can really count on. So overall, we're seeing 90% of our littles have strong feelings of being listened to, feeling better about themselves, and having the confidence that they will achieve their goals.
We just did a full analysis 2 months ago. Over 80% of the kids that we see, their trauma symptoms get better, their behavioral and emotional functioning improves, parents are at decreased risk for child abuse, parent psychopathology improves. So treatment works, but it's not a quick fix. You know, we're talking about, in many of these cases, complex trauma. We see kids for an average of 27 sessions over the course of a year, and that's an average. For some, it's years worth of work. And that's why I really think the focus on how can we find treatment for these kids that's not time limited, that's affordable and accessible, so that they can deal with all of these issues in a time frame that it's as long as it takes, right? These things don't go away overnight. And so I think it's positive news, but it definitely takes resources and community effort.
And it's worth it.
Absolutely.
Yep. Awesome. Awesome. Hunter, I'll toss it back over to you. I'm sorry I went over time, but this was just such a good discussion.
Absolutely understand. First, we just want to say thank you to each of you. The expertise that you guys bring and the unique perspectives and the individual ways that you've found to serve your military communities has been really impactful. And we hope that this discussion really helps spur kind of those ideas and conversations for our partners and those viewing. As they continue to see how they can best support and address military children's mental health. For the Q&A, I want to be quick because I know we're about out of time. Had a really great question regarding families of fallen military. What does it look like for grief counseling? So you're kind of that step beyond potentially, having that veteran who was there or that family member who was there. What does it look like? Are you changing your perspectives or the way that you're interacting with these children as you're doing grief counseling and maybe that step further of just beyond mental health counseling? And whoever wants to answer, I don't know who would be best.
I mean, there's definitely techniques that are specific to trauma and loss, and traumatic loss, such as that can be really helpful. But group intervention is also profoundly helpful. And there was, I believe that National Military Family Association, NMFA, does Operation Purple Camp, and they do some that are specific to families of fallen service members that might be really helpful to kind of give that commonality and support to a family that's experienced that sort of loss.
I have a shout out to another really great program is Wear Blue Run to Remember has a Gold Star Youth Race program. And they pair Gold Star Youth with a mentor who's also connected to the military, and they work towards running a 5K. And so that's a program we've worked with locally and supported. And it's another great opportunity to bring the families of the fallen together and provide a support system, but also experience healing and recovery and wellness through movement, and speaking the names of the fallen and sharing those stories. So in addition to those mental health treatment and support around grief is really that building that community and that connection with other people and staying connected to the military community if that's what they choose to do.
Wonderful. Thank you both so much for your insight on that specific question. And we are out of time. Once again, thank you all so much for your time and experience in this topic. It's really beneficial. And as somebody mentioned earlier, military children's mental health is in a state of crisis. And the more that we can work together to address it, the better our whole community will be. So thank you all. Have a great afternoon.